mission to improve the human condition through healthcare leadership. And I believe that improving the human condition through healthcare leadership is exactly why we are gathered here tonight. I'd like to begin with a quote from Martin Luther King, who said that injustice anywhere threatens justice everywhere. We are all caught up in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one of us directly affects all of us indirectly. You would think that by now we would have sufficient knowledge of our inescapable network of mutuality. HIV/AIDS, for instance, which was thought initially to be a white gay man's disease, showed us that it had no regard for race, gender, sexual orientation, socioeconomic status, level of education, or any other construct that we have created to categorize, separate, divide, or oppress. And yet, the resources and supports needed to prevent or treat HIV/AIDS have been inequitably distributed, and so too are the outcomes. Fast forward to COVID-19, where the same communities prone to the most devastating effects of the disease have the least amount of resources. Communities where people may not have access to healthcare coverage, or the ability to prevent or manage chronic conditions, or be able to exercise or create a plan for nutritious eating. These are the people who are also least likely to be able to work remotely during this crisis. Despite such a challenging and depressing reality, I do have hope, in part because you all are here tonight. I have hope because of our distinguished panelists who will be led through a critical conversation by Tracy Brown, an award-winning author, expert, speaker, and leader. And I hope that this conversation does not end tonight. Rather, I hope that it ignites change by inspiring each of you to illuminate the disparities that exist within your organizations, your communities, the places where you reside, where you worship, where you congregate. We need to make change. And given what we are up against, it is critical for each of us to shine as brilliantly as we possibly can. Because as King also said, darkness cannot drive out darkness. Only light can do that. So I hope that each of you will shine your light in places where darkness may have otherwise been left unexposed. And together, we will improve the human condition through bold, transformational, visionary, and inclusive healthcare leadership. Thank you. And now I'll hand it over to Tracy Brown.
Good evening, everyone. Everything that Dr. Stefan just said is so important. And I agree with him. You would not be here for this panel this evening if you didn't already know that you can make a positive difference. And what a panel we have. Oh my goodness. I have worked in and around healthcare for several decades, and I want to assure you that this panel is a very special one. You've probably already read the bios, so I am not going to bore you by repeating all of that. But I just want to remind you that you have an opportunity this evening to get insights and to get ideas from Tiffany Capellas related to and connected to CHRISTUS Health. You have an opportunity to hear what happens from an operations perspective and a clinical perspective from Jim Allard from Medical City Children's, Medical City Women's Hospitals. You have an opportunity to hear from Dr. Ajit Pai, who is the president of a hospital and brings a perspective from both pharmacy and from hospital operations. And you have an opportunity to hear from and to be inspired by Dr. Carlos Ramirez, because we all know that what happens in the emergency department gives us lots of information about where the real issues lie, where the real weaknesses are, and where the opportunities to shine brightly are most available. So I don't know about you. I don't know if you are a fellow of ACHE. I don't know if you are simply someone from the community who cares about these issues and concerns, or maybe you do work in healthcare, but you are in some other operational or administrative role. What I do know is that there will be something for each one of you as we go through this evening. And we're going to start off with a question that I want you to hear from every person. Because if you are like me, since the beginning of this year, there have been 2 or 3 times when the reality and the seriousness of the COVID-19 public health crisis really hit home, where you said, oh, I've known about disparities in healthcare, but oh wow, this makes it real. Or maybe you said that you knew about viruses and how they affect the community, but then something happened or someone said something. So I would love for each panelist to start off by sharing, as a leader or as a healthcare professional, what caused you to wake up? What were one of your wake up and take notice moments related to the issue of COVID-19 and healthcare disparities? And Jim, would you start us off?
I'd be happy to. Thank you, Tracy, and thank you, Stefan, for getting us started. I think as a healthcare leader and as a chief nursing officer, what came to mind to me was the fear of the unknown. I think many of us went through this same phase, and personally and professionally, locally and nationally, we didn't know how this disease was going to really impact on us and on our businesses. And so when I think about that, I think about the fact that we organized very quickly to figure out how we were going to take a surge of patients within our facility. And so quickly started looking at predictive models to see how other countries were dealing with this pandemic and how could we best prepare. So disaster has not been something I've not dealt with, but this type of event I have not had to deal with. So very quickly, we had the opportunity to learn, to plan ICU beds, med-surg beds, and I don't think it was until I started seeing senior centers and prisons and those individuals being impacted at significant numbers, not recognizing that they couldn't social distance, and that this truly was hitting families all across the local area as it was in other countries. I think it was then that I really woke up and said, gosh, we're really in for it. This is something that we weren't really prepared for. And then to treat those patients and then try to get them back to a senior center was even more difficult because those senior centers weren't prepared to take back a COVID positive patient. So really, that is really what woke me up. I think that we have an opportunity to partner together to look at all of the health disparities, communities that need support, communities that have large families, communities that need education. And I think in order for us to do that, we're gonna have to pull together as a collective in order to make change across the continuum. So thank you for allowing me to share some initial thoughts.
Wow, those wake-up calls are so real, and that really gets us started. What about you, Dr. Carlos? What was it? Was there a moment? Was there a moment?
One of the things that really struck me the most, it was the fact that in emergency medicine, in health systems, we are prepared for everything, and we're ready for everything. And so we believe we have health systems which have enough infrastructure to deal with anything. And all of a sudden, a pandemic comes, and it really uncovered how unprepared we were for this particular situation. It was absolutely amazing how much we failed to provide the healthcare in a timely manner, healthcare accesses. There was a lot of issues that we needed to include. We deployed a bunch of resources, including telehealth and some other things. And at the end of the day, we didn't know what else to do. We communicated a lot of other things to different specialties. We were ready to open a bunch of beds, and then we run out of oxygen. We ran out of resources, and it was not enough to have the capability and the capacity to treat those patients. It was, what is it what we're doing? What is it what we're doing with the communities? How are we preventing these from continuing to spread out? And so it was an awful awakening at all levels during this particular situation. So definitely it was an extremely good learning opportunity for us in healthcare.
Wow, the running out of resources when you're trying to really provide the best possible care is one of the most challenging things that any of us could face. And so thanks for making that real, like really real for us. What about you, Tiffany? What was your wake up moment?
You know, for me, my wake up moment, I think I'm gonna have to take us back to my childhood and my lived experiences growing up in the distant suburbs of Cleveland, Ohio. And having experienced the challenges that my parents had accessing care and healthcare, I realized that social determinants was going to play a huge role in this pandemic. And that's something that I have dedicated my life work to, addressing those social determinants of health. And when a lot of the conversations were focused, and rightfully so, on PPE, on clinical protocols and procedures, and how do we appropriately resource, our leadership at CHRISTUS challenged us, you know, all hands on deck. We need all hands. We've never been through this before. So think about, where is it that you can help us to navigate this? And immediately I thought, wow, what happens to multi-generational families, such as my own growing up, when you can't social distance? When you're not the one that has the luxury to be able to work remotely, what happens to those instances? And you know, I have to share this. It was very telling when I went to 2 different grocery stores in one day, and one was a more affluent grocery store and was in more like a discount grocery store. And this is very, very early on in the pandemic. You saw individuals at the affluent grocery store, they were not masking. And into the other community that was a discount grocery store, they were fully masked. And I thought, wow, are we in the same city? And in the interesting dynamic in how that played out, I thought, here's an opportunity for us to get ahead of this at CHRISTUS. And thank you for the opportunity to be able to share what we've done, and how we can, as a healthcare community, be a resource to everyone as they're impacted by this pandemic.
What a powerful story, an example, because you're right. Sometimes we do have to ask ourselves the question, wait, is this the same city? Is this the same county? Is this the same world? And that could be based on socioeconomic, that could be based on race or ethnicity or sexual orientation. There's so many identity groups. And so that's a really good way to get us thinking about what a difference it can make as we go or interact with each different community, and as we try to provide care to every community. So Dr. Ajee, what about you? Was there a moment, well, I'm sure there have been several, but what's one of the moments where you really had a wake-up call related to COVID-19 and disparities?
Yeah, thank you, Tracy. And you're right. There have been many wake-up calls along the way, many learnings. It continues to occur every day as we continue to get more and more data around what we're experiencing. For me, the earliest recollection around the potential for health disparities was early on in the pandemic. So in the March, April timeframe. During that time, I was installed as the chairperson for the Asian Healthcare Leaders Forum through ACHE. And also during that time, there were news reports that showed there was an increase in verbal and physical abuse targeted towards Asian Americans. Actually, in late March, the FBI put out a warning of an increase in hate crimes against Asian Americans. And this was specifically related back to the rhetoric that is used for COVID-19 and has been used throughout the pandemic. And so in discussing that with our forum and our committee members, it certainly offered an opportunity for us to connect. And we actually heard from one of our committee members about a specific instance that he experienced as a hospital operator in a different part of the country of discrimination that he endured in trying to serve the community. And that really struck home with me. That was disturbing to hear, and actually reminded me of an experience that I had on September 11th of 2001. I worked an afternoon shift of that very day, came in, had facial hair much like I'm showing today, and my boss at the time mentioned to me that I looked like a terrorist. And, meant in jest. At the time, I kind of brushed it aside, but certainly in having some time to reflect on it since then, it impacted me deeply. And it created social stigmas and a fear of safety and how I fit within the culture and how people looked at me. And so that gave me a chance to really connect deeply and empathetically towards what Asian Americans might be experiencing and our Asian community might be experiencing as we're going through COVID-19, and ultimately what we can do to ensure the good tenets of public health. So around safety and trust, we talk about access to care and having those points of care available, but folks need to feel comfortable and safe and believe in the meaning of the information being shared with them to be able to seek out that care and ultimately get tested and of course know, so we can prevent that community spread. And so certainly for me as the son of immigrants, it's important to be mindful of how those populations interact and what those words mean for them. And so that gave me real deep insight and empathy into what the Asian American and Asian community was experiencing early on, and certainly raised a flag for me of potential disparities as we move forward in managing the pandemic.
Wow. All four of you have just put a personal face on this crisis, on what we are all experiencing. And I get to work with organizations and leaders and associations all over the country, but you're reminding me why my favorite industry is healthcare. And, I get to work. It's like a joy for me to work with people in healthcare because of what you just demonstrated. Like this commitment to care, this commitment to quality, this commitment to making the community better, and at the same time, not losing sight of the personal nature of it. We're talking about this tonight as a public health crisis. And what I hope you've done is trigger for everybody who's participating, for them too to make their personal connection. But let's dive a little bit deeper into this public health nature of this crisis. So why don't we continue with you, Ajit? When we talk about the COVID-19 pandemic as a public health crisis, what role actually, like how would you summarize the role of the public health infrastructure in responding to COVID-19?
So I certainly want to start off by saying I'm no public health expert, but I feel like we've all been on a crash course through 2020 to learn. So, obviously from a public health perspective, the goals are to prevent disease, promote health, and prolong life. And I would say in all of those components, it's been a significant challenge, especially here in the United States, in managing through those goals. A pandemic alone, obviously, is a public health emergency. And, to talk through the challenges we have on the infrastructure side, would probably take a bit more time than what we have here right now, but we're clearly in a crisis. I think we've also got a prevailing infodemic that we're trying to manage as well, that is preventing us from maybe fully grasping and putting our hands around what successful practices we can put in place. From a macro view, for the United States, how we're doing, we account for 4% of the world's population. But as I checked our dashboard this morning, we're accounting for 25% of the cases worldwide and 22% of the deaths. So obviously, there's a disproportionate amount of cases and deaths here in the United States. And when you look at public health infrastructure and really our tried and true methodology that the US really invented and perfected and has used and supported throughout the globe to contain outbreaks, we're looking at testing, contact tracing, and then isolation and quarantine. And we've really had a challenge around many of those and continue to go through cycles of challenges. And that infrastructure is just essential to containing the virus. It includes our public health departments, our government agencies, our policies that surround that, but it also includes that partnership with private organizations and nonprofits around healthcare provision. So, ultimately, to be successful and work as a true infrastructure in partnership, there needs to be transparency of data and real-time sharing. And in parts of the country where they have seen some successes, that has done well. And then I think, I think Dr. Allard mentioned earlier, we've seen some successes around the globe where certainly, that infrastructure and partnership has worked really well. But it all comes back to that testing, contact tracing, and that isolation and quarantining. And I'll give real quick, here in Cleburne, we had an issue around testing early on. And we were able to partner with our community folks here in Cleburne to set that testing center up. It was much needed and certainly provided a successful partnership, but more needs to occur and really around that data sharing and real-time information sharing to be successful.
Yeah, thank you for that. That's a really good encapsulation of so many issues, but it reminds us these are the things that we're thinking about, and these are the things that need to happen and the things we need to track. It's especially interesting to me, as you mentioned, that the percentage of cases and deaths from COVID-19 for the United States is disproportionate to our population in the world population. And within that, right, if we only look at within the US, the disproportionate distribution of our deaths and our cases based on these topics that we're talking about, creating disparities for different identity groups, has really, really had a spotlight on it. And a lot of the conversation has been about screening and treating those who are COVID suspected. How do we deal with screening and treating those who are COVID positive? So Jim, I'm just wondering if you can provide, it's not, everybody knows a little bit about it, but what comes to mind? What have been some of the barriers that have really made the healthcare disparities pop out in statistically around COVID suspected screening and treatment?
Thank you, Tracy. I think that when we look at the screening and testing that's been available, I think the fear instilled people wanting to be screened and wanting to be screened regardless of whether or not they had symptoms. This created, kind of mass pandemonium because we didn't have enough testing supplies. We didn't have enough swabs. We didn't have enough platforms to actually run the test. We had companies racing to provide platforms, and you had, the local or public authorities, asking those testing sources to be given to hospitals first, because typically the sicker patients are going to be going to the hospital. But then we had the rest of the general public that wanted to be screened and didn't have access to be screened. So I think over time, as more platforms came out and cities organized and governors organized, they were able to create other locations to test people, and they could actually broaden the scope of who was able to be tested. And so I think that was a barrier initially, as well as time of test to time of result. Initially, it could take anywhere from 48 hours to a week to get a result, depending on who did your test and where it was sent. We were fortunate at our facility that within about 6 weeks, we had a platform right at the hospital that we could actually run tests within our own lab. So that allowed us to then plan for like in my space, elective deliveries. So moms are still gonna have babies. So we still have to care for them. And so initially we were having to treat them all like they were PUIs. And so you can imagine the waste in PPE when this person probably didn't have COVID, but we didn't know. So we had to protect our staff and the other patients in the facility. But as testing improved, now we're at a place where we can pre-test 72 hours in advance before a mom comes in for an elective surgery. Or if they show up unexpected to deliver and they've not been tested, we can do what's called a rapid test. So things have evolved where it's safer and it's more operational. But I think it's impacted disparities across the spectrum.
Thanks. So Tiffany, let's turn to you. You gave a really powerful example and shared that from your childhood even, you have been able to recognize how bias shows up. And there's a really popular phrase that's being used now, unconscious bias. It's really not anything new, but people are using it a lot more. As healthcare professionals and leaders in healthcare are trying to assign resources and deal with shortages and deal with the unknown that is COVID-19. We've not ever experienced it before. What are some of the ways you've observed unconscious bias showing up in the way that different communities are receiving resources or different patterns of clinical care or even different clinical outcomes?
Sure. So when using jargon like this, I wanna kind of explain it for those who may not be familiar with the term. Unconscious bias, it really goes deep into how we think and how our brains have developed. You've got the fight or flight segment of your brain that looks at making quick decisions when in a traumatic situation. You've got to make a quick decision. Then you've got that middle state, that limbic system that is able to go more off of feelings, and you can actually do some processing in that brain state. And within that brain state, however, there are limitations. There's limitations in that when you are under stress and you're trying to kind of think objectively, you're not able to fully take in all sources of information. And so then there's another brain state that is the higher level brain states. That's our prefrontal cortex. And here, this is where you can employ more executive functioning and thinking skills to take in information from multiple aspects and process it and check your own biases. Where do our biases come from? They come from our lived experiences. They come from things that we've heard, from church, from the community, the neighborhoods that we've grown up in. We all have biases because we are human. And when we look at healthcare, this institution, but it's run by people. It's run by people. We all have biases. So inherently in healthcare, these biases are going to show up, especially within a pandemic, when we are not able to function at this higher brain state. We've got to make quick decisions. We've got to move to action, and we've got to move quickly. We have millions of lives depending on us. So within that, we have seen unconscious bias show up. In which that has shown up. Let me give one example, and this one is not local. This happened actually to my parents. I'm taking from personal experiences. They went to, because they were feeling ill, my mother placed a call to find out if she should get testing. And among the list of questions that she was asked was, are you a US citizen? What is your country of birth? You know, these questions, she was taken back, and she is not a US, she's a US citizen, but she was not born here in this country. She's a naturalized citizen. And she was taken back. She was offended by the question. Her interpretation of this was, wait a minute, if I wasn't born in this country, does that mean I'm not going to be tested? Does that mean I don't have access to the services and the resources that are being made available? What was the messaging that we were putting out there? Upon further investigation, because she called me, shared her thoughts, and because I work in this field, of course, I'm passionate about this, I moved to action and contacts within my network, find out that the public health department had issued these questions. It wasn't the health system. It was the public health department that put these out for everyone to ask. And it was to get to, had you traveled outside of the United States within the last 14 to 30 days? That was the purpose behind asking, what was your country of birth? Because somehow that would lead to, oh, you've traveled. Or are you a US citizen? If you are not, then maybe you've traveled. I'm not quite sure how that rationalization came into play, but of course, upon questioning, they did change those questions. But that is an example of how unconscious bias can come into how healthcare and also how healthcare can be accessed and what we're putting out there. Another example would be our deaf and hard of hearing community. Masking was immediately something that there was discussion about first, no, there's not going to be, masking is not going to be a big player, but then later we found that yes, it can actually help and has been extremely helpful. But when it comes to our deaf and hard of hearing community, they communicate with their full body, and having a mask on inhibits the ability to communicate effectively. So by utilizing the mask, the traditional mask, they weren't able to do so. Now what we're seeing is that there are masks that are clear that you can actually see someone's mouth and fully have a conversation with someone. So those are two examples. I want to be mindful of my time, but there are many other examples. And I will say this, within healthcare, we have a number of professionals that are doing everything they can to meet the needs of all of the patients. But again, these unconscious bias thinking, mass populations, mass decision making, special population groups can get missed. And this is why having people at the table who understand these communities is incredibly important.
Thank you, Tiffany. Those are perfect examples, and examples to get us thinking about all the assumptions we make. And so thank you also for talking a little bit about the definition of unconscious bias, because that is what gets us into trouble so often, especially when we're moving fast, trying new things, and being faced with decisions that have to be made quickly. One of the things that has really shifted in many healthcare organizations is the ramping up of digital health and telehealth. And there are multiple sides to that as well. It's been really helpful for us to be able to assess and to be able to respond and to be able to for us to treat, but also there are the same kinds of equity considerations that affect the effective use of digital health and telehealth. So Carlos, maybe you could share a little bit of a perspective about that.
Oh, I was on mute. And so listen, Tracy, you're gonna have to keep me in time because I'm gonna talk a little bit more. And let me just kind of share with everybody about what is to be on the trenches. Um, how is really to deal with um, a person who's probably in the 80s, who comes with a back of a family of 5, all of them sick with COVID, and this individual dying within 5 hours upon arrival, and having to talk to the rest of the family who live in a household of about 15 to 20, having a language barrier, and sent by via Skype because they don't let anybody to come in. That is a heartbreaking situation, and that's something that is really personal. Indeed, we have a lot of good stats on this, and probably the message that I want to carry out to everybody is engagement, and that was the key, in my opinion, about many things. And indeed, I'm going to talk about the telehealth and what we've done. But the problem with what I see, and talking about Tiffany's bias, I think we anchor very quickly in this process, and we satisfy everything into, we need to respond as an emergency basis, and we somehow didn't put in the center patients understanding that they have a lot of other dynamics outside. Indeed, we have telehealth screening for COVID-19, and we developed all of this infrastructure, and we did everything from step 1. In other words, telehealth is a great product. We are monitoring, we're tracing, we are reaching out to patients, we have screening algorithms, but we didn't deal with anything else other than being able to capture and try to maintaining patients at home. But we didn't even improve anything. We didn't link primary care medicine with emergency medicine, maybe some specialists to transition those patients using telehealth. I think we have a tremendous opportunity to provide specialized care through telemedicine. We have the capability to do some of the things, but we didn't link, for instance, radiology services as an opportunity to be done in a remote access. We didn't link the transition of certain patients involving primary care medicine through the telehealth, and we didn't even involve some of the specialties in a timely manner, using a tremendous opportunity for the telehealth and communications. We saw a tremendous engagement via telehealth at the beginning of the crisis, and then we saw a tremendous drop. People didn't find the value of that as much as we thought they would. And it was our fault, and I think from the health systems, to engage in a much better way, centralized telehealth that is a tremendous tool to really help out the population outside. So that's probably what I wanted to share with everybody on this. We have telemedicine became an enhancement of the primary care mainly, and it's been used for years and years. People know primary care, know how to use it, but the problem is when that came to our hands, we provided a sub-service, if you will, to the population because we didn't hear anything. We anchored very quickly in the process, and exactly what all my peers here said. Hey, listen, we were ready. We tested. We did a bunch of things. Yes, indeed, we tested. We knew people had COVID, and then what? What did we do about providing more health care, health resources, screening tools through telehealth to those individuals at home? Those type of things is what really I can say about telehealth.
Perfect. So, wow, you all have brought up some really important things for all of us to think about. There have been some specific mentions of certain identity groups, LGBTQ, citizenship or immigration status. We've heard a little bit about people with disabilities, people of Asian heritage, socioeconomic status. You've touched on a lot of things as we just laid this foundation related to public health, related to screening and treatment, related to all of these different aspects. So before we open up to questions from our attendees, is there anything that any of you want to add, like additive, either additional examples or maybe an idea that hasn't been expressed yet related to how our differences and how our variances in care are impacting our response to this? And I'm seeing some heads shaking. So does that mean, Carlos, you want to jump right back in?
Most definitely. I think what I would like to share with everybody, and this is just coming from my own experience and just trying to bring everybody at the table, we need to put the patient in the center of the conversation and understanding what is it what the end customer wants. If we don't understand that, if we assume that they want testing, or I assume they want better care of the emergency room department, we're leaving a tremendous areas that we didn't cover through this crisis. And we realized, and we started to realize at this point, by the way, people who may live 2 hours away from here, they may have to share one ride with somebody who may have COVID, contamination, cross-contamination. What is it what I'm using? We've never, ever, ever, believe me, I handle more than 13 facilities in emergency medicine. None of them called the family medicine team or the primary care team to say, hey, listen, what do you think about this? How can we reach out to those guys? Other than screening and screening and screening, nobody just went further and say, hey, listen, how about education? Can we go to the communities, find out what they do? What transportations do they have? Do they have to go to an only grocery store in town where they may get infected? None of that happened. The involvement between the cities, the government, and hospitals and healthcare facility in us, it was only reactive, but never ever was proactive. And that's something that I learned very quickly. And it was a painful learning curve, at least at our facility.
Yeah, so important. Thank you for highlighting that. It's really a serious concern that we have, that we're dealing with, and we are dealing with it. But I'm glad that you all are bringing forward the seriousness of it, the challenge of it, and the impact of it. Who else wants to add?
Yeah,
something?
I was going to mention, Tracy, that, certainly what Carlos mentioned all rings true with what we've experienced in our facility and community as well. Prior to the pre-pandemic, we always knew how important family members were. We generally have more of an elderly population in our facility. Certainly from a hospitalization rate perspective, it trends a bit more on the elderly side for COVID. But pre-pandemic, we always knew the family was important to the care, and then also to ensuring good outcomes once the patient left the facility. But to kind of expand on what Carlos was mentioning there, having the patient at the center, but really realizing how important that family unit is to the success of that patient, not only in ensuring that the family stays safe and is knowledgeable, but how important it is for them to understand and be there. Tiffany talked about the deaf and community and the need for masks and talking with your whole body. I mean, when we talk about medical jargon and information, to have that tactile ability to see that learning occurring on the other side, to be able to have that conversation face to face, to be able to do it through a telehealth or a Skype session is a good intermediary when you have nothing else, but it's so difficult to really validate that teach back method, that they're really being able to absorb that important information that helps to continue to keep that patient healthy and well and informed and what they need to do. And it just highlights again that the deconstruction of the care continuum outside of sometimes of our facilities, and certainly the need as a community, along with our local government officials and public health officials, to work together, to collaborate, to ultimately better serve our patients and community. But that's certainly been a highlight. We've done all those things that Carlos mentioned around that telehealth component to connect those family members, but it really, really, truly highlighted how important it is to the success of those individuals and those patients and ultimately the community at large.
Perfect. So for those of you who are attending, just be thinking about if you have a question that you would like to ask a specific panelist, or if you have an example of something that you might want to share that you experienced or learned or practiced in your health system. I would just ask that as you're thinking about it, get really clear so you could summarize your question in about 25 words or less, and or make your comment as briefly as possible. And you can go to the Q&A. We'll be looking at those in about 4 or 5 minutes. But while they're thinking about that, Jim, what do you want to add? And then Tiffany, is there anything as well that you want to add one more key point? So Jim, let's go to you next.
Sure, I'd be happy to. So this was back to actually what Tiffany had mentioned in one of her earlier comments when, she was saying to herself, are we in the same place? As we think about PPE and, the general public masking, when they're out in public or they're close to one another and taking that seriously. I remember my daughter, 17, and had her first job hostessing at, I would say, a restaurant in an affluent neighborhood, and she got put on furlough for a couple of weeks. And Tiffany's story made me remember this because she was sad she got put on furlough, but she's like, I know other people need jobs, and, I don't really need to work. I can make myself busy at home. And when we finally had restrictions lifted, she got called and they said, we're going to start opening at 25%. Would you like to come back? And, she thought about it, and, we told her we would support her, whatever she decided. And so her boss said that they weren't going to be wearing masks. And that really bothered her. And she brought that to myself and my husband and said, I can't go back there. And I said, absolutely not. You can't. I said, you call your manager back and say, if I can't wear a mask, I'm not coming back. And so it made me think of what Tiffany said, that there were some people that were just not heeding the advice. Even though I understand the advice is complicated and the CDC recommendations changed, it seemed like sometimes daily, if not weekly. But that's significant on the population. So I just wanted to kind of share that story.
It's a great example. Tiffany?
Yeah, so I did want to share that at CHRISTUS did a proactive approach before the media outlets started to talk about the social determinants, the disparities that were existing. We were already doing outreaches to our suspected and COVID positive patients, doing assessments to see what were their needs. Did they need food delivery or drop off, grocery shopping, prescription assistance, transportation, whatever their needs were, to connect them with community resources. And one of the things that, and Dr. Ramirez touched on this, as healthcare institutions, we really have to do a better working with our community organizations that exist. I think this whole pandemic has highlighted how siloed public health, healthcare, hospital systems are, community organizations are, and we really had to work together. And I think we're getting there, but early on, we were able to mobilize in that way. And now where we find ourselves kind of expanding is in leveraging that telehealth, providing remote patient monitoring to patients, so that we are able to get patients home faster. And if they are on oxygen, if they need oxygen, then they can get that oxygen. We can monitor them remotely. We've got sending them home with peripherals to be able to collect what their readings are, having them take anxiety surveys, the GAD-7, the PHQ-9 depression screening surveys, So we're able to monitor how they're doing as well from a mental health perspective, and also doing shortness of breath surveys to see, how are they doing? Do we need to have somebody contact them? We also provide automated messaging depending on what those readings are. So how are we leveraging technology to meet patients where they're at, regardless of what services they actually qualify for? So at CHRISTUS, we have a pilot where, regardless of type, we're sending them home with services, with peripherals to collect these these data that they can input into an app. And what this is doing is enabling us to reach minority communities, uninsured communities, and give them the satisfaction of being able to heal at home, being connected to community resources. If they need someone to walk their dog, if they need a grocery drop, whatever they need, they can recover, further prevent community spread, as well as give providers peace of mind that they can discharge that patient, maybe do an early discharge to send them home, and that there's somebody that's watching them. So just to share some ways in which this is a time for innovation, right? This is a time where we can really tap into how do we meet people where they're at, and look at how do we leverage the opportunity to push for policy changes so that telehealth, oh my goodness, we struggled with telehealth in Texas, but yet look at what we were able to do so quickly when the pandemic hit. So let's leverage this time to get those policies changed that need to be changed so that we can get our billing and our all of those things that we need aligned, we can make them happen.
The best leaders always turn chaos and calamity into creativity, into innovative solutions that you just mentioned. And actually, my experience is in North Texas. We have a track record in the healthcare industry of doing that. So I expect that we will continue to move forward more rapidly. But something else you said, Tiffany, is a great link to the first question that we have. A good plan is only as good as the weakest link. That said, many in the public don't believe the science. So what are some of the ways that your medical staff, this is for all of you, and we'll hear from a couple of people with quick responses. What are some of the ways your medical staff is supporting community education?
So I will just jump in from as part of our outreach, we are providing health education to our patients on how do they prevent spread within their household if they have many people living in their household, to their caregiver in their home. How do they protect themselves and if there's children in the home or elderly in the home, how to protect them? What are steps and provisions that they can take? That is something that our care managers are also providing and granted, it's a limited population because it's only for those that we are outreaching that are suspected or COVID positive. But it is education nonetheless, because when it's shared, it's then you get a phone call from a friend and they're sharing and passing that information on. So that's one way in which we have done that at CHRISTUS.
Yeah, and at Texas Health, I would say, from a system perspective, we put out resources and guides and things like that from a medical staff perspective. But I would say, we have 25,000 employees throughout THR, and from our CEO Barclay Burdan, his leadership has guided us that we're all responsible to not only make sure we're following through on good public health processes when we're out and about, to make sure we're staying well and can continue to follow through on the commitment we have to the community to care for them when they have times of need. But we can also be out there proselytizing, for lack of a better word, about what the truth is, and ensure that we're connecting with family and friends and helping to support what the true science states and what they can do to protect themselves and their families.
Perfect.
Similarly, at HCA, we've had lots of dialogue from our corporate partner in Nashville or a corporate office in Nashville down to our division offices, really to collate information, assimilate information from all of the experts, and try to get that information in the hands of our healthcare providers, whether it be the nurses or the physicians, so that we can have conversations with our patients and hopefully get that information out to the community. So, you know, obviously in the Women's Hospital, we're working with many obstetricians' offices, so we've helped provide them with resources to provide their moms. So that's another way we've kind of helped in our area.
Fabulous. Carlos, do you want to add anything before we go to the next comment question?
The only thing is we need to be fair with this particular situation. And the reason for that is it was surprising. So we were caught out of guard and we didn't know about this. We're learning the process. However, we learned so quickly by month number 2. And so we had data, we had analysis, and we had things that really made us to be better. Now, we're doing so many testings that obviously we're just finding more cases, mathematically speaking, than the rest of the world. In Uganda or anywhere else, in Colombia, whatever you like, they're doing less amount of testing. So of course, mathematically we're doing more and we have more cases. But it doesn't mean that it's a valid statistical data. But we learn from our own data, New York, New Jersey, Washington State. We learn very quickly. The other thing is we're using technology. The question is whether we're using the technology in the proper way. We're just reaching out home. We have better access, faster access. We're becoming more personal. The question is, are we doing the right things with the right resources? Are we thinking for the patient, or maybe the patient is involved in the conversations to listen, what is it what they want at the end of the day, or I'm making the decision, I think you need this. And so my experience has been bringing at the table, the community really has helped us to understand what is it what they need. Believe it or not, something as simple as educating employers on this particular situation, just going to the different employers and say, listen, you know, this strategy is okay. We're gonna be here engaged with you if you need us. And as simple as that really make a whole difference for the communities.
So often when we talk about community education, we think first of one-on-one with the patient, with the family. But thanks for that reminder that when we really want to extend community education faster and to larger people, that it is important to educate through the workplace, through employers, educate through churches and spiritual communities, educate through community organizations. And so I love that you added that reminder as you were ending your comment. And of course, that's a great connect to this next question, because education is a part of it, and the technology and the statistics have shown us, if we only look at our own data, that the impact upon communities of color and other minority communities has been disproportionate. So the question that is asked is, what are some of the pressing needs for minority communities as COVID-19 affects certain groups? So who wants to jump in on that one? Some of the pressing needs for minority communities as COVID-19 affects certain groups.
I'll jump in, just kind of kick us off. I think when we look at the kids going back to school, we have a number of children, minorities, who don't have access to internet. And when you see those who are able to go to school remotely, and then there are those here in Texas, we've got our schools opened up for children who don't have access to internet. Those are the children that are now getting exposed. So when we think about our minority communities, communities of color, these children have a higher exposure rate. Children of parents who cannot work remotely. They work in public facing jobs. And they don't have the luxury of working remotely, so they have to be sent to school. We're going to continue to see these disparities perpetuate themselves because of the systemic racism that still exists within this country. And we have to be ever so mindful and cognizant. I think the racial protests have really brought to light and highlighted that this is an issue that we have to look at as a whole, not just, it's not a healthcare issue. This is a national issue. This is an issue that we all have to own and we all have to look at. There are a number of challenges that the minority communities face when it comes to the chronic disease comorbidities that they have coming into being diagnosed with COVID, and how that further complicates the health of an individual and being able to make it through and recover from COVID. So those are some additional elements that we within healthcare have to consider and look at. But we also have to look at what is the exposure that these individuals have at a much higher rate than other communities.
Tiffany, I can be more agreeable with you. Definitely, we need, I think, and this is just my personal opinion, I think we need to reflect and say, okay, our reflection is what? What is our next step on this? Is only COVID driven, or is diabetes driven, or is hypertension driven, or is cholesterol driven? What is it what we're failing? What is it we learn about COVID that is gonna have to make us to change our mind how we're gonna approach the communities, mainly one of those minorities who have different challenges. And me as a health system, what is it what I'm doing? Because providing the access point, it is proven that is not enough. And so now systematic approach, collaboration approach is what is gonna bring a tremendous value for the next maybe 90, 120 days, and applying the knowledge that we have about COVID and just kind of transpolating to a much better and a more robust system, whether it's hypertension, hyperlipidemia, cardiac disease, amputation, vascular disease, you name it. We have now the experience on a very short viral, I'm not trying to demerit or diminish the virus. I'm trying to say COVID is just a sample of what we have in our hands that is allowing us to understand the need of those individuals and minorities, whether Hispanic or African American population, Indian population, or you name it, whatever. We have individual challenges, and this is opening our eyes for a need for change.
And Carlos, you bring up a really important point that what we're seeing is symptomatic of a bigger issue, and I think we all know that. We only really have time for one more question, and what I'm going to do is combine two into one and ask you, a couple of you, to respond as succinctly as you can. So I'm gonna read excerpts from two because they're really related. COVID has disproportionately affected the Hispanic population. Many in those communities are afraid to seek care because of immigration status. What can we do to address this challenge? And Hispanics make up 41% of the population, but 57% of positive COVID-19 cases. This will put additional drain on resources and require methodical thought on planning, sustainability, the need to build stronger relationships. The question, how are your organizations partnering with others to not only provide outreach, but also build trust? So this idea of really making an effort with the Hispanic, Latinx communities, with the fear around immigration status, What can we do to address this? What can we do to build trust? And are there ways that you are partnering with others to make this happen? Quick responses, please, because we could spend an hour and a half on this one question.
Yeah, that's significantly the challenge of all of these topics tonight. I mean, and I'm again just appreciative of the chance to engage with this group. And in regards to the Hispanic population, I think certainly at the core of what we do in healthcare is trust. The patients, the communities, when they come to us for their care, they're trusting in us to provide that care for them. And in doing so, all that we do, we talk about politics being local, healthcare is local. We've created many relationships in our communities, whether that be through faith-based, through business-based, what have you, many different relationships throughout our community. And I think this is that time, in those times of crises, where we need to leverage those relationships, as Carlos said, to bring those folks to the table and listen, not assume that in the old world of medicine, which was very paternal, and we just tell you, here's what you need to do, take this medicine and move on, but really flip the table and listen. This is the time to listen and learn and hear from our community members and build upon those relationships so that we can better serve them and understand the fears and the things that surround them in forcing them to make the decisions or keep them hidden from what we've been able to do for other parts of the community for many years. So in a small snippet, certainly that's something. And then real quick, I'll add to that, Tracy, is just additional data that we're getting from this. The disaggregated data, normally we get very aggregated data around groups. So I'd say for Asian Americans, we get it all grouped in under Asians. That's, as with any group, it's not a monolith, right? We're all individuals. We all have different stories and perspectives. And so my hope here as well is to get some disaggregated data so we can really drill down on where those issues are and begin to leverage those community partnerships and resources to truly make change.
Great. Every one of you could probably talk for 15 or 20 minutes about this. And as Ajit just said, the most difficult thing is condensing and providing some key points, some food for thought in the limited time that we have. But I don't want us to close without hearing from each one of you. And what I'm going to invite you to do is just in a couple of minutes, either share what's your call to action to everybody in healthcare? What's your call to action to leaders in healthcare right now as we are dealing with the COVID-19 pandemic? Or what gives you hope? What gives you hope related to this issue that we've been talking about with the disparities that have been spotlighted? What gives you hope, or what call to action would you share with others? And let's start with Jim and then go to Tiffany.
Thank you, Tracy. So I think most importantly, I'm proud to be a nurse and proud to be a nurse leader. You know, Gallup, for the 18th year in a row, Americans have ranked nursing as the most trusted profession in the country. And it makes me proud to serve in this capacity, as I've been for the last 22 years. What gives me great pride is those nurses that have pulled together to help us create treatment teams and staffing patterns to help support the patients that are coming in that are COVID positive. To what Dr. Carlos mentioned, a nurse that takes the time to hold the hand of a patient that's end of life while family is on video is extremely impactful to that person. And we all know that if you're a nurse or a healthcare provider, you're the first person your family, of your non-healthcare friends, your non-healthcare colleagues, they call you first for support and resources. So I have to put my hats off to everybody who's taking care of our patients. And then related to the pandemic in general, it's elevated healthcare disparities in the eyes of the public and politicians. And I think, you know, along with racism against Black Americans, you know, it has definitely made me awaken as a leader to educate myself so I can have crucial and open conversations, uncomfortable conversations with my leaders so that we can impact the front line and we can help staff at all levels. And I think it's going to take all of us to be able to have those uncomfortable conversations from the front line to the boardroom in order to help make change when it comes to healthcare disparities. So thank you for allowing me to kind of share my thoughts.
Perfect. Tiffany, and then Carlos.
Great. So I'm going to leave you all with a call to action. It's going to quite pick up where Jim left off. It's important that there is representation of your community in your boardrooms, in your governance, your executive leadership, amongst your director level mid-management in your facilities. That is critical, not only amongst management, but also amongst the teams, the special task forces that are put together to work on these important initiatives. We need to have that representation at the table. Another would be to ensure that when it comes to these issues of health equity, having those brave conversations about race, that you are engaging your clinicians. There are, at CHRISTUS, when we've put out a number of different resources, we've launched a racial justice educational campaign, and a number of our clinicians have come out and said, we want to be a part of the solution. There are a number of individuals out there who want to be a part of this work. Engage them. Don't be afraid to have those conversations. Another would be to measure. I know we talked about data paralysis and there's so much data out there, but there's nothing more powerful than your own data. Your own data tells a huge story. There's a lot of national and state data, but your own community can really, really give you the ability to make informed decisions. If you're not looking and stratifying by race, by ethnicity, by age and gender and payer status, socioeconomic status, using payer as that way of looking at that, you're gonna miss a lot of things in ways in which you can have a greater impact within your community. And then lastly, engage with your legislators. This is the time in which we can really make progress. Healthcare is so highly regulated and it's so difficult to see change take place. This is the time. The time is ours. The time is now. We can do it. So don't hesitate to do that. And if you don't know how, your governance teams are eager for your expertise and your support. So again, they will guide you through that process.
Thanks, Tiffany. Carlos, and then Ajit.
Oh, you're on mute.
Oh, is that with me, right? Okay, so the only thing that I would say is take a deep breath, you as leaders, and ask yourself, are we doing the right thing at the right moment for the right person at the right time for the right price? If all of the rights come, then probably you're in the right path. But if you have to justify something, probably you're not doing everything right. If you say, yeah, we're doing this, but if you have to justify something, most likely you're not doing the right things. The second thing is, whenever you meet with a purpose. Don't let meetings be just so open when you're talking about minorities. If you do that, then you're opening to a forum that is completely useless. In other words, if you go and you want to work with your leaders or your executives or whomever, and then you say, we're going to talk about the barriers that we have with the African American population in hypertensive disorder and COVID, you name it. I mean, people will bring all kinds of ideas. If you come with the goal that says, listen, we're going to decrease the percentage of X, Y, and Z, and we need to bring to the table cardiology, pulmonology, ER physicians, whomever, and then we're going to develop the plan to be successful, that is a meeting with a purpose. And that's something that I found. And the data, make sure exactly what Tiffany said, get the data, but get the data about outcomes. Utilization resources, that is secondary. Just get the outcome. What is it what you want? Reduction of, utilization of. You know, the data for success is important that you have a goal. That's my 5 cents on it.
Thank you. Ajit.
Yeah, thank you. And you know, certainly something that I want to touch on that I'm really proud of. First of all, some of us on this call would maybe consider ourselves competitors, but I'm really proud to be working in partnership with all of you throughout this pandemic. It's been amazing to watch each and every one of your teams step up to the front lines and do the necessary work to come to our calling during a time of need for all of our communities. I'm additionally proud of the efforts that Texas Health and UT Southwestern are doing right now to launch the DFW COVID-19 prevalence study. And this goes back to understanding where that distribution and spread is throughout our community, and not just looking at certain folks who would respond to a survey, but really intentionally going out to those high-risk parts of the population, those essential workers, to really understand where that prevalence is occurring and how that's impacting our minority populations. And then again, call to action. I think we've got to get comfortable in healthcare, having our voice heard. We've got to find our voice. Everybody on this call has a influence, has the ability to find their voice and influence others and lead. And we've got to get comfortable of being out front. This has certainly identified an opportunity for us and given us a platform, if you will, to be able to speak on behalf of the communities we serve. And I think we need to get comfortable being out there and being out front and talking through these difficult subjects and making it real for the people we serve. And ultimately, as Tiffany mentioned, get prepared for November 3rd. Go out and vote, be involved, understand how that impacts your community, and be out there, and again, be out front.
Wow, there are so many directions this conversation could go, and I am so grateful for being here and being a part of hearing and being reminded of the things that are important. I mean, there are places that we could go that I encourage everyone in their own communities, in their own healthcare facilities to go to. We focus primarily on what's been happening and what we need to do right now, but we can't look very far in the future without asking and thinking about the considerations of representation or lack of representation in clinical trials. We have to be able to really dig into immigrant and mixed documentation status and how that relates. We've got to be able to move forward in having people at the table, as Carlos and several others have said, and not just arbitrarily make decisions from a limited point of view. So much of what foundation has been laid over the last 15 or 20 years related to disparities now is the time to take it to the next level. So I'm going to end us with a quote that is this one from Abraham Lincoln. "The dogmas of the quiet past are inadequate to the stormy present." The dogmas of the quiet past are inadequate to the stormy present. Now, I know that in my time in healthcare, I don't know if there's ever been a really quiet past. There's always change happening. There's always the new thing. There's always the challenge. But I bet for some of us and many others, these last 5 months have felt like a stormy present, and the past seems quiet by comparison. Thank you to each of the panelists. You have given me, and I'm sure many others, lots to think about and to take action on. And I'm going to pass this back now to Barbara.
Wow, thank you, Tracy. And to all of our speakers, this was even better than I thought it was going to be. Amazing conversations, and it's been so great. to hear everyone's insight and learn from everyone. So thank you so much for taking the time to be here, and of course to our attendees for coming today. So as a special thanks to our speakers and an appreciation of their contributions to this event, ACHE of North Texas is making contributions in their names to the ACHE of North Texas Leadership Legacy Fund. This fund has been created as a portal through which individuals and organizations can make contributions honoring healthcare leaders and in support of future healthcare leaders. So thank you. 100% of these monies are contributed to this fund, go specifically to career advancement of current and future generation of healthcare leaders. Thank you again to Dr. Stefan Davis and UNT Health Science Center for hosting us today. Thank you again to all our sponsors and to everyone for attending. Have a great night.
All right, thank you.